Okay, so we'll turn the webinar here on in just a second. Very excited about this. I'll basically introduce you, and then we'll let you take over the screen and have fun. So if people have questions, I will relay those to you. Do you prefer to take those towards the end?
I think it's probably best.
Okay, all right, we'll do that. So we're ready to go. Are you ready?
Mm-hmm.
Here we go. Well, welcome. I'm very excited to say hello to you here for our Life Co-Pilot, basically living with Parkinson's disease expert panel today. I'm very excited. We have Dr. Aaron Ellenbogen with Assistant Professor of Neurology in Oakland University, Beaumont School of Medicine in Rochester, Michigan. And you've got a whole bunch of other credentials as well. I want to let you explain all those and what those are, and I'll stay out of that. So, Doctor, why don't you go ahead and take over our screen and tell us what we need to know today.
Okay, thank you very much, Jim. I'm just going to get this going here. So, good afternoon, everyone. This will start with a video and then go into additional presentation.
I was in my mid-40s when I first started experiencing symptoms. I had some stiffness in my right arm, but I didn't think much of it until someone else noticed. I'll never forget that moment. I was in an improv class standing on a stage, and the teacher said, "What's going on with your arm? You were stiff." I knew something was going on, but I didn't know what. That's what led me to go see the doctor. I was referred to a neurologist that told me to simply walk. In less than 5 steps, he said, "You have Parkinson's." I was at the pinnacle of my life when I found out I had Parkinson's. I had a good job. I had a fiance, and I was eating, breathing, and sleeping improv. I loved being on stage. I'd always dreamed of becoming an actor or a comedian. I was living my dream. And boom, my life just took a drastic turn. I started taking treatment, but as the disease progressed, my symptoms got worse. When my levodopa medication wore off, I would freeze or have off time. 1 minute I was walking around just fine. And the next minute I was stiff as a board. My doctor gave me more levodopa to help with the off times. For years, play around with the dosage. But as time went on, I began freezing up more. And I just couldn't do anything. I couldn't bathe myself. I couldn't mail a letter. And I started having dyskinesia, which is a side effect of levodopa. It's just a lot of involuntary motion, intense shaking and flopping around. A couple of times where I was actually bouncing off the walls of my house. And this was different from tremors. Could happen at any moment. It's like when you're performing on stage and your mind goes blank. It's embarrassing. I had pretty bad sometimes. I would go out to dinner or go to a ball game with my friends. I would have to tell them, though, you have to understand that if something happens, we're gonna leave. One time I went to a restaurant with a friend of mine, and I just couldn't sit still. Little boy was sitting next to me and just staring at me. I knew I needed to find a treatment to help manage these off times and dyskinesia. There was a drug called Gocavry that could help reduce dyskinesia. The drug later got approval to treat off episodes as well.
What is Gocavry? Gocavry, amantadine extended release capsules, is a prescription medicine used for the treatment of dyskinesia, sudden uncontrolled movements, in people with Parkinson's disease who were treated with levodopa therapy or levodopa therapy with other medicines that increase the effects of dopamine in the brain, with levodopa and carbidopa in people with Parkinson's disease who are having off episodes. It is not known if Gocavry is safe and effective in children.
I asked my neurologist about it. He talked to me about the benefits and the potential side effects, such as hallucinations and feeling dizzy. So talking to my doctor and doing more research, I decided to give Gocavry a try. I am doing well on Gocavry. Just take 2 pills every night before you go to bed. I noticed improvement in my symptoms. Because my dyskinesia, my off times have been reduced. I feel comfortable participating in more activities. Take out the garbage, get the mail, walk down the street, get a cup of coffee, go out to dinner, go to a concert. This is just my experience. Yours may be different. I still have bad days, but it never occurred to me that my life was over with Parkinson's. In improv, you never know what's going to be thrown at you when you're on stage. You have to take what you get and run with it. Just make it work. And that's how I approach my journey with Parkinson's. Roll with the punches and just keep going.
What is Gocavry? Gocavry, amantadine extended release capsules, is a prescription medicine used for the treatment of dyskinesia, sudden uncontrolled movements, in people with Parkinson's disease who are treated with levodopa therapy or levodopa therapy with other medicines that increase the effects of dopamine in the brain. And also used with levodopa and carbidopa in people with Parkinson's disease who are having off episodes. It is not known if Gocavry is safe and effective in children. Important safety information. Do not take Gocavry if you have severe kidney problems. What should I avoid while taking Gocavry? Do not stop or change the dose of Gocavry before talking with your doctor. Call your healthcare provider if you have symptoms of withdrawal, such as fever, confusion, or severe muscle stiffness. Do not drink alcohol while taking Gocavry, as it can increase your chances of serious side effects. Do not drive, operate machinery, or do other dangerous activities until you know how Gocavry affects you. If you took too much Gocavry, call your doctor or go to the nearest hospital emergency room right away. What are the possible side effects of Gocavry? Falling asleep during normal activities. Activities may include driving, talking, or eating. You fall asleep without being drowsy or warning. Suicidal thoughts or actions and depression. Tell your doctor if you have new or sudden changes in mood, behaviors, thoughts, or feelings, including thoughts about hurting yourself or ending your life. Hallucinations. Gocavry can cause or worsen hallucinations, seeing or hearing things that are not real, or psychotic behavior. Feeling dizzy, faint, or lightheaded, especially when you stand up. Orthostatic hypotension. Lightheadedness or fainting may happen when getting up too quickly after long periods of time, when first starting Gocavry, or if your dose has been increased. Unusual urges. Examples include gambling, sexual urges, spending money, binge eating, and the inability to control them. The most common side effects of Gocavry include dry mouth, swelling of legs and feet, constipation, and falls. If you or your family notices that you are developing any new, unusual, or sudden changes in behavior or related symptoms, tell your healthcare provider right away. These are not all the possible side effects of Gocavry. Call your doctor for medical advice about side effects. You may report side effects to the FDA at 1-800-FDA-1088. Tell your doctor about all medical conditions, including if you have kidney problems, have unexpected or unpredictable sleepiness, sleep disorders, or currently take medication to help you sleep or make you drowsy, are pregnant or plan to become pregnant, or are breastfeeding or plan to breastfeed. Gocavry may harm your unborn baby and can pass into your breast milk. Tell your doctor about all the medicines you take. Include prescription and over-the-counter medicines, vitamins, and herbal supplements. Especially tell your doctor if you take medicines like sodium bicarbonate or have had or are planning to have a live flu vaccination nasal spray. You can receive the flu vaccination shot, but should not get a live flu vaccine while taking Gocavry. Please see full patient prescribing information at www.gocavry.com.
Okay, well, just to start, when I see a story like that, I find it to be actually very rewarding. Having been involved in the clinical trials that ultimately led to the approval of Gocavry, participation in those kinds of trials is actually rewarding from the sense that we see the impact that it has on people's lives. And so as a result, when I hear stories like that, it makes me feel very good about some of the work we've done because of the positive impact we can have on people's lives. So as Jim had introduced me before, I'm Aaron Ellenbogen. I am a movement disorders neurologist in the Detroit area at a place called the Michigan Institute for Neurological Disorders, and am an assistant professor of neurology. So you've heard all of this, what is called fair balance about Gocavry, but just as a reminder, and it was in the video, Gocavry is actually indicated for people who have dyskinesia, so those twisting, jerking, Aldopa-based therapy. And it can be used with or without concomitant medications. It also can be used adjunctively to treat carbidopa-levodopa, or some people will refer to that as Sinemet, which is the branded formulation in patients with Parkinson's who are experiencing off episodes. And so that is when people can tell when their medicine is wearing off. It's between doses, occasionally can be unpredictable. So we're going to talk a little bit more about these off episodes in dyskinesia and really try to help you understand what these are. We'll also talk about the impact they can have on daily life, talk about why we treat these motor complications, and really some strategies to do so, as well as the treatment options. So early in Parkinson's disease, one of the things that happens is people will sometimes experience and most often experience what's called a honeymoon effect, or really from a technical standpoint is considered a long duration response to medication. And that means that people will take a dose of medication and they can't tell the difference from one dose to the next. When they first started on medication, typically they will say that they felt improvement in their symptoms, whatever it may be, tremor, stiffness, slowness of movement, they're walking, and so on. But if they miss a dose, or sometimes even several doses, they may not see the impact of those, and certainly don't see the impact of an individual dose. And so from that point, as the disease progresses, we start to see that people can begin to notice the positive effects of a single dose. So they can see that the dose helps to treat their symptoms. And then they can also see when the effects of that dose start to subside or wane, and they see reemergence of their symptoms. That reemergence of symptoms is what we will refer to as the off time. And what's going on in the is that the brain has the ability to buffer levodopa, which gets converted to dopamine, and then release it in a more dopamine. However, over time, as the disease progresses, we lose that ability to buffer it, and then we start experiencing off time, where people notice that their symptoms are reemerging and they can have slow movement, tremor, rigidity, walking or balance difficulties. What can also occur is dyskinesia, and dyskinesia is working as expected in some ways, in that it's helping to ameliorate the symptoms that are typical of Parkinson's, the slowness and tremor and so on. But it also is leading to these extra involuntary movements, and these are distinct from tremor. And I think the video does a nice job of really conveying this, in the sense that the tremor is something that is rhythmic, it's regular, and it's something that has a certain rhythmicity to it, whereas dyskinesia is inherently irregular, and the movements can be relatively small, or in some people they can be quite large. And if you can envision Michael J. Fox, he experiences dyskinesia, and you can see his whole body twisting and turning at times, whereas when his medication wears off, he has a very short stride, has hunched posture, you'll see tremor, and so on. And so the good on time is that area that sort of falls in between, and this is when the levodopa is working the way that we want it to, and we're not seeing dyskinesia that are interfering with function. And so that's really what happens in the early parts of Parkinson's, when that honeymoon effect is occurring. But we still have periods of time where that seems to be happening as the Parkinson's disease itself advances. So just some other things so that we can have some shared language. Bradykinesia is a term which means slowness of movement. And that's really an obligate feature of Parkinson's, and certainly can be one of those things that reemerges as a symptom as medication wearing off. Rigidity or stiffness is another key symptom. And then tremor, which again, people who have tremor in Parkinson's, the classic tremor is at rest. And again, it's very rhythmic. And then people can have postural instability or falls. And any one of these can be a reemergence of symptoms. One thing that I think is often a common mistake that we see when people talk about their tremor, when someone holds their hand out in front of them and says, I'm not doing anything with my hand is at rest. This is actually not at rest. At rest is when the arms are relaxed, the hand is relaxed, the hand's sitting in the lap, and everything is very quiet and relaxed, and you start to see the tremor reemerge. Oftentimes with that rest tremor, people can actually think about their tremor or concentrate on trying to alleviate it, and they notice that their tremor improves. Many times once one starts taking medications, these symptoms of off can be well controlled, but again, over time, they can eventually reemerge. So we've talked about tremor and the shaking or trembling movements, and they can occur during off periods. And I've also talked about dyskinesia already, which again are these jerky, can be dancing-like movements, writhing, twisting, and they can occur especially during on periods. But occasionally there are people that have a more complicated pattern where they can actually occur as the medicine is kicking in or wearing off. And that pattern is a little more challenging to treat and is called Diphasic Dyskinesia. One of the advantages of a medication like Gocavry in treating dyskinesia is because Gocavry helps to improve on time and not just, or reduce off time, and we see a subsequent improvement in on time, and treat dyskinesia, we can sometimes manage dyskinesia, whether it's a peak dose or related to that diphasic pattern. So motor complications, again, are very common, and this is really just indicative of the disease progression. Everyone who has Parkinson's, it is a progressive condition. So if things are really static for a very long period of time, that's a good thing if they have Parkinson's, but sometimes it's actually a pause for thought and just reevaluating the diagnosis if there's really no change over time. As you can see here, that as many as 50% of people with Parkinson's may experience off episodes within 2 years of starting levodopa. Interestingly, there was a trial called the Aldopa Trial that was a 40-week trial that actually showed about 14% of people experience it even in that first 40 weeks. So that is not uncommon just as the disease progresses. Dyskinesia, again, is not uncommon, and you can see as many as 30% of patients will experience this within 2 years of starting levodopa. And so as a result, we see that over time, the numbers on both sides of these, the off episodes, which are called motor fluctuations, or the dyskinesia, accumulates with duration of disease. And so 50% of people who are using levodopa will experience off episodes, dyskinesia, or both within 5 years. And certainly by 10 years, we're approaching nearly everyone. I never like to use an absolute or all because there's always an exception, but the point being that the longer someone's had Parkinson's, the longer they've been on levodopa, which is the gold standard foundational therapy to treat Parkinson's, the much higher prevalence of these problems really emerges. So just looking at some of the trends in how we treat Parkinson's, there's about 1.1 million people in the US who have Parkinson's disease. And you can see that there's still a fair number that have not been appropriately diagnosed and started on treatment. But there are about 724,000 that have been diagnosed and treated with levodopa, and you can see that about 475,000 experience these motor complications, which are the fluctuations and the dyskinesia. And so, again, we often see that, off and dyskinesia go hand in hand. It's more common to see off periods before we see dyskinesia, but occasionally we do see the reverse. And then one of the things that we know for sure is people who are young onset Parkinson's, and that by definition is people under the age of 40, are at higher risk of developing these motor complications. Now, 40 may be the drawing line in terms of calling it young onset or not, but quite honestly, someone who's diagnosed at 41 or 45 often behaves much more like someone who's considered young onset than a person who's diagnosed at 75 or 80. And so there is certainly some areas around the margins rather than just a hard and fast rule. in terms of that and those behaviors and how the disease progresses and behaves. One of the issues is that sometimes a treatment strategy adopted is that we will limit levodopa because we want to try to reduce the dyskinesia, and patients many times will make the choice to do that. However, more commonly, we actually see patients prefer to have mild dyskinesia, but have no off periods or reduce off periods than to have the off periods. What many of them tell me is that they're much more uncomfortable with the off periods than they are with dyskinesia, as long as the dyskinesia are not severe. Again, they both have a significant impact on patients. And I think that's really, really clear. They can be interfering with social interactions with friends and family. People may avoid social situations entirely, which leads to isolation. It can also impact work. We see greater risk of disability in patients with these issues, as well as the fact that it can be unpredictable in some cases. And I think unpredictability in managing any chronic disease is one of the biggest factors that we face and encounter in trying to manage it, because providing a little bit more predictability for our patients in the end is really something that I think is critical in helping to manage any condition, and certainly Parkinson's disease. So, again, there are different approaches for managing off episodes. It can be altering the foundational therapy of levodopa. There are a number of medications that can be added on to try to address off time. Some of them work on dopamine, some of them work in other pathways, and there are even surgical options such as deep brain stimulation. There are some other surgical options as well. And then another approach would be to use the foundational therapy of their levodopa plus a medication that's approved to treat both the off episodes and dyskinesia, and that's Gocavry. So when we adjust levodopa, what happens is you decrease it and you increase the potential for off time. When you increase it, you increase the potential for having dyskinesia. And sometimes it's really hard to strike that balance. What this good on time really is reflective of is something called the therapeutic window. And the problem with trying to get into that therapeutic window is as the disease progresses, that therapeutic window narrows. And it almost is like trying to thread a needle to get into that space where you have good on time without those troublesome dyskinesia or having off episodes. And so you can see this narrowing. You can imagine how difficult it may be. And that's why in some cases where people experience relatively frequent fluctuations, we have them taking doses of medication, really relatively modest doses, as often as 2 hours. So the reality is, what's nice is having a medication that doesn't necessarily require us to sacrifice good on time, but simultaneously can help us reduce dyskinesia. And that's where Gocavry fits in. So one of the things that's nice about Gocavry is it's simple. It's easy for people to use. They take it at bedtime. And what happens is, because of the delayed release technology, you gradually start to get a rise in blood levels during the course of the night. And then we really see very nice coverage during the course of the day in terms of therapeutic levels of this medication in the bloodstream. And so this allows for coverage during the course of the day and reducing dyskinesia at the time where it really tends to be most troublesome, but simultaneously we do. And that really in the end is what happened from the pivotal trials. We see that 30% decrease in dyskinesia. And one of the things I like about the video, some of the things that Dave doing, for example, the impact of dyskinesia on dressing. And this is an activity that actually is measured in the studies right out of the UDysRS, which is a rating scale for dyskinesia. Again, we saw a 36% reduction in off time and simultaneously a 29% increase in good on time. That's good on time, meaning there were no troublesome dyskinesia. So again, this is a medication that really attacks both ends of that target of reducing the off time, but also reducing dyskinesia. So we can see here just a sample diary plot for a single patient. Off is gray, good on time is green, and the yellow is dyskinesia. And you can see how that looks. But what happens is that by adding Gocavry to their regimen versus someone who got placebo, we had more good on time throughout the day. And that's meaningful for people. And what happens is the less times they're sort of cycling through these periods of either dyskinesia that are troublesome or having issues where they're having off time, the more challenging it is to manage the day. And so providing more on time can translate into better predictability for patients and allows them to manage their days a little bit better. So possible side effects of Gocavry, and this was again all covered in the video, but people can fall asleep during normal activities. And this is something that be aware of with just Parkinson's disease and medications for Parkinson's in general. People can experience suicidal thoughts or actions or depression. Hallucinations are one of the more common potential side effects. And in people over the age of 65, this is a little bit higher risk than those of people under the age of 65. The good news is, if this occurs with Gocavry, almost invariably when the medication is discontinued, then we see resolution of those hallucinations. Having lightheadedness or dizziness, especially when standing up, which can be associated with a drop in blood pressure. This is something that is not uncommon in Parkinson's and can affect nearly 20% of people. And the medications we use to treat many of the symptoms of Parkinson's actually can exacerbate this. But the most common side effects were actually dry mouth, swelling of legs and feet, and then constipation, as well as falls. And so if you see any of these side effects, certainly first and foremost notify your provider, but you're also able to notify the FDA to report side effects as well. And capturing this data can actually be very important because it fills out the picture of potential side effects with this medication that weren't necessarily all captured in trials. So of course, before taking Gocavry, you want to talk to your doctor about any medical conditions, such as kidney problems. This is something that may need to be dose adjusted or not used in people with severe kidney problems. If people already have daytime sleepiness or fall asleep suddenly or unexpectedly, if people don't have well-controlled depression, or have things such as suicidal thoughts, or if you're already having hallucinations. Impulse control disorders are another issue that we see in Parkinson's disease and with the medication. There's this warning about alcoholic beverages as well, and it's simply because it can enhance the sedation effects that are potential with Gocavry. And you've heard about the fact that this has not been studied in pregnancy, and there's a risk to unborn babies, and it can be transmitted in breast milk. And again, just as a reminder, sometimes medications are prescribed for purposes other than those listed in the patient information. And this is something that is called off-label use. It's just a reminder that, obviously a physician has the ability to do this, but certainly don't give Gocavry to other people, even if they have the same symptoms. The active ingredient is amantadine hydrochloride, and you can see all the other inactive ingredients. And one thing that you need to make sure of is that your providers should know about any medications you're taking, but also supplements. So things that are over the counter, vitamins, herbal supplements, and so on. And then, of course, the reason that there's this warning about live flu vaccination, which is usually nasal, is amantadine originally was a medication used to treat influenza A. And it turned out that it had an impact on Parkinson's and Parkinson's symptoms, but it can because it can still have anti-influenza effects on influenza A, it can make the nasal spray formulation of that vaccine ineffective. So the one thing to remember is this is easy, simple nighttime dosing. It's one capsule initially and then 2 capsules at bedtime, unless they're dose adjusted for some reason. And then it really does provide coverage during the course of the day. And so that can make a substantial difference for people to improve their overall off time by reducing it and improving their control of dyskinesia and overall improving their good on time during the course of the day. So one of the things I think that's really important is, and I ask my patients to do this, is track your symptoms. I compliment patients when they come in with a list of things that they want to discuss, because that means they're driving the visit, and that allows us to really address things that are important to them. If you are having movement problems, it's important to record those and also to try to relate them to the timing of when you're taking your medication. Having a care partner with you can just serve as an accessory memory. So there's someone else who has observations and may remember things a little bit differently than the person who's experiencing them. And, obviously it's important for myself as a physician, but other providers to know what are the problems that are impacting daily routine. And this allows you to really create and lead a discussion with your doctor. And there is a discussion guide that you can use from gocavry.com as well. And you can certainly talk to your doctor about that if it's appropriate. And then if you and your doctor decide that Gocavry is an appropriate treatment for you, there's an onboarding process. And so there's a single point of contact. They can help with prior authorizations. For patients who need financial assistance, they can help with that as well. There are foundations to support people who have federally funded insurances. And so people may qualify for that. In addition, for people with commercial insurance, they have a copay program, and there's a patient assistance program as well. So there's all sorts of different avenues, because in the end, this treatment can only be effective if people have access to this. And so it's something that Supernus has been very, very supportive of, and really supportive of the Parkinson's community in general, with their entire portfolio of medications to treat Parkinson's disease. So hopefully today you've learned what off episodes look like and how they relate to levodopa and dyskinesia, which can relate to high levels of dopamine, how adjustments of medication can be helpful, but oftentimes as that therapeutic window narrows, it's really difficult to manipulate medication to get people in that sweet spot. And so by using a tool like Gocavry, it allows us to actually find that sweet spot a little bit more easily and reduce both off time and potentially reduce dyskinesia. And then the simplicity of it is that it's just once daily dosing at bedtime. And what I'd like to do now is really just stop and see if there are any questions that have come in.
I haven't seen anybody pop up with questions yet, but I was going to say I have a couple. One is I just saw on there was like a onboarding thing that program. They say it is not available if you have Medicare, Medicaid. Is that correct, or how does that? What's that?
Well, we still are required to use specialty pharmacy for this medication. So there is an onboarding process even for those individuals who have Medicare or Medicaid, but some of the support isn't available to those with federally funded insurances. And so Medicare and Medicaid are federally funded. Even for a subset of government employees who have federal insurance, they're not qualified. They don't qualify to receive some of the benefits like the copay of $20. But for people with Medicare and Medicaid, they can still avail themselves of that foundational support, for example.
Okay. So it is covered. It is a covered drug class or what have you for those.
Well, that varies from insurance to insurance, but I mean, it is FDA approved. And so, there may be differences in formularies, but when being used on label, it's certainly something that we often are able to get approved for our patients, even if there's a couple steps we need to go through.
Okay. So what is the, so this basically, you said there was an initial dose and then a nightly dose. Is it just like, one time initial dose and then from there on out, it's every night, or how does that work?
So if one follows the labeling, then the initial dose is one at bedtime for a week and then up to 2 at bedtime. And for most people, that 274 milligram dose at bedtime is the right dose. There are occasionally people that have their dose adjusted, or certain providers may use alternate ways of building up the medication. There's a smaller dose available because it can be dose adjusted for people with kidney problems. So there are some people that may start as low as 68.5 milligrams. And for some people, that's the right dose, especially if they have kidney issues that would preclude higher doses.
Oh, okay. So it's not that like an initial dose and then that's just kind of how it gets you up to speed to the
Exactly.
your body adjusted to it or what have you. Is that correct?
That's correct.
Okay. So who is the person that is most you're a movement specialist neurologist. So what is who's the person that's most likely the best client for this, or the person that should be looking at this?
So to me, the person that I think of first is the person who has dyskinesia when their medication is working, but they're also experiencing off periods. That is the sweet spot, because this is a medication and it's the only medication that's actually indicated to address both of those problems. Now, that being said, there are people that are experiencing dyskinesia that are troublesome and interfere with their function, that don't really have off periods, and we still will use something like we will use Gocavry in treating those patients because it is effective and it's the only FDA approved treatment to treat dyskinesia. So any one of those I think are really the first people that I would think of. I mean, there are also people who simply, because of the fact that they experience off periods, because of the approval for that aspect of treating Parkinson's as well, this can be an appropriate therapy for those individuals. But the key really is, and this is with anything in Parkinson's, is about individualizing therapy and trying to find the right medication or combination of medications for each patient. You know, I tell people all the time, you know, there's 1.1 million flavors of Parkinson's disease, because each person is a little bit different, even though there's some common themes.
You know, I was just, you know, the 1.1 million people that are diagnosed with Parkinson's, these are people that you said they're not being treated. Is that what, you know, some of them only like 700,000 are being treated or what have you?
Well, so there's two things. Number one, there are people that haven't been diagnosed,
Okay.
haven't been diagnosed appropriately. And then there's some that for a variety of reasons, including patient preference, have elected not to start therapy.
So are they of that 1.1, some of those are not diagnosed. That's an assumption that they're there, or what is that?
Based on statistical modeling and
Okay,
and so
all right. Because I was going to say, I know that, you know, I have a family member that has Parkinson's and went undiagnosed for 4 years, or was misdiagnosed for 4 years. They kept trying to say it was arthritis or what have you, and then actually, believe it or not, had a heart attack. And while in the hospital, this one doctor goes, "I think you have Parkinson's. Let me try." You know, gave her meds, and it was like amazing. So that's how we found out. So
sure. It
I
can be a
understand that
difficult
that's
diagnosis.
common.
It can be a difficult diagnosis, and certainly there are, for the 30% or so of people that don't have the classic tremor that we think of, it becomes a little more difficult. You know, statistically, a movement disorder neurologist will get the diagnosis right about 90% of the time. A general neurologist less frequently than that, and certainly in the primary care setting, it's less frequent than a general neurologist in terms of making the right diagnosis.
What's the credentials do you look for in a movement? I mean, is there a letter number that we're looking for, a letter designation, or is it just
I mean,
Googling
sometimes
movement disorder? Yeah.
you know, there's a couple of places. So there certainly, there's no letter designation, so it doesn't say MDS after my name in terms of my credentials. Although, you know, there is a repository of at least some of the movement disorder specialists through the Movement Disorder Society. And then, you know, really, if a person is looking for a movement disorder specialist and they're having a hard time, a lot of times there are community resources. So being in Michigan, there's the Michigan Parkinson's Foundation, which really serves people in Michigan to help them find someone who may be close to them, or if they want another opinion, et cetera. And so I know there are Parkinson's support groups in Indiana, throughout the state of Indiana. There's a very nice, robust system. And so there's opportunities to connect with organizations like that that can also help find providers accordingly.
Well, we have, I noticed that Kim Williams from who's the director of the Indiana Parkinson Foundation is watching this today as well. So we have a really good resource here as well from her. So.
Absolutely.
So what now, when the last time I saw you, I got a chance to see you when you spoke in Indianapolis, and you were talking about kind of, well, it was kind of like an EpiPen type thing for someone that's having an off period that is out and about. Would you like to tell us a little bit about that while we have you here?
Sure. So, you know, the medication that you're referring to is called Apican, and Apican has been around a really long time. It's a nice medication because, as opposed to something like adjusting levodopa dosing or adding a medication like Gocavry, which is every day, which still may be very appropriate, this is something that's an on-demand therapy. So some people will refer to it as a rescue, where when someone experiences sudden wearing off of their medication, or they're late with their medication and forgot to take it, it's a way of dosing a medication, and it's a small injection that is like an EpiPen. And a lot of people say they don't even feel the injection, but that medication can start to work as early as 5 minutes, and it provides relief of the symptoms for somewhere around 60 minutes or so for most patients. And so again, it's to fill in those gaps. But a medication like Gocavry is an effort to try to eliminate or reduce the gaps in general, so that they can be used in a complementary fashion in many cases, because of the fact that they serve really different roles in treating people who have Parkinson's.
So you could actually use this whole suite of medications, as far as if you have your ongoing, the normal Parkinson meds, and then you've got this one that's going to reduce all these different dyskinesia and off periods. But then if you get someplace and you're out to a restaurant and all of a sudden freeze up, would that the other one would come in? So that one person, without overdosing themselves, could work with all three? Or
Well, yes, they could. I mean, the key is, of course, working with a healthcare provider who's going to help them manage
yeah.
it. But yes, I mean, that certainly is a very plausible scenario. And I have a number of patients who we do exactly that.
Okay. Well, that's interesting because, I don't think a lot of people know that these other options are out there, so you said that the one's been around for a while. This one that we talked about today, is this predominantly pretty new, or?
I mean, it's relatively new, but it's still been out for a few years at this point.
Okay.
And I think that, there's, unfortunately, for a variety of reasons, the pandemic notwithstanding as well, I think that there have been issues of getting people to understand its role, and with marketing, simply because of the challenges we faced over the last couple of years.
Okay, well, so it's because our family's been dealing with it for a long time, and you're the one that introduced me to both of these. I'd never heard of either one of them, so it's kind of like, okay, there's more out there that people know about. So
Oftentimes, yes, and unfortunately, I mean, especially, some of it will relate to sophistication of the provider too. So, I mean, I would expect a general neurologist to know more about this than a primary care physician. I would expect a movement disorder neurologist to have even more expertise with knowing how to use the tools that we have on the market today.
Excellent. So what kind of recommendations do you have to people that are out there that aren't sure, that they're, maybe they are new to Parkinson's, maybe they are undiagnosed yet, and they're in that group that's out there that have been misdiagnosed because their general practitioner hasn't figured it out or whatever. Do you have recommendations for people that suspect there's something wrong, how to go about getting?
Well, I mean, I think that the local resources like the Indiana Parkinson's Foundation is a great place to connect, because they can help with community resources in terms of providers as well. And I tell my own patients this: never be afraid to get a second opinion. Just from what I ask them is, if they want to go see someone who I think is a really viable second opinion, tell me, because I'll make the recommendation myself. And most providers won't be offended or won't be upset if you tell them you want to get a second opinion, just because of the fact that you want to make sure that, to validate what they're doing, or to know what other options and other ways of approaching treatment of, in this case, of Parkinson's disease. It's one of those things that if you were to line up 4 or 5 movement disorder specialists, we will still not all be in agreement on how exactly to treat an individual. There's a lot of nuance, and there's a lot of experience and skill that comes into play with this. And so, there are different strategies. And one of the things is that, if I'm not right with the strategy I take initially, I have to take a step back and shift gears. And every once in a while, I'll say to someone, I'm not quite sure why this isn't working, and maybe it's worth getting another opinion. And so having those discussions is also really important. And it's okay to seek another opinion if you're not happy with how things are going, or even if you are, just so you can learn what other options may be out there.
Well, that's excellent. So, well, I'm very excited about this. I think that this is, I think Parkinson's is greatly misunderstood. I think before we went live, I was talking to you about the fact that it's amazing how often when you go as a Parkinson's patient into a hospital setting or a care setting of whatever, trying to explain to the medical staff there how it works and why the meds need to be done on time, they kind of blow you off, like, well, you don't know what you're talking about, you're just a layperson. And then but it does mean a great deal when time is an essence on some of these things.
Absolutely. And I mean, that's a is that they and it's not just the understanding, but sometimes it's simply an issue of manpower. So in Michigan, the regulations are such that they have if a medication is ordered at a specific time, they have a window around which they can administer that medication. So it's, even if it's ordered for 5 p.m. exactly, they have a window, and the problem is that if you stack those windows together, it can really lead to quite wide variation. Medications are administered, even though for the person with Parkinson's, that extra half hour or an hour can make a substantial difference. And so it's hard to convey that information. And one of the things that I encourage families to do in those settings is to try to, and again, we've been lucky, we've developed the Michigan Parkinson's Foundation, we've tried to develop some tools to convey the importance of that timing, so that can then be conveyed to providers, and whether it's a hospital setting or a long-term care facility, et cetera.
Yeah, I think that's been one of, from our own experiences having to deal with that. I mean, my loved one basically is supposed to have her pills every 3 hours, and 5 a day, and oh my God, all of a sudden you're getting it 5 hours. Well, that doesn't work. Then you basically the whole thing is crashed, so it's,
exactly. And then you're either getting medication too close together or too far apart. And if it's too far apart, you're digging yourself out of a hole the remainder of that day.
Well, another thing we've been, and I actually, you were talking about this the last time I saw you speak, that I thought was very interesting. You were talking about the actual main drug that people use is absorbed through the small intestine, and if you have proteins that you've eaten at basically the same time, the protein absorbs and the drug doesn't. And like, we were in a therapy situation, and they were talking to the dietitian who was talking to about what they were doing, and they were going to increase the protein at the same time. I'm like, you got to do this, you got to spread this out. But it's like, and when we were telling them that, it was like, this is a care facility. They had never heard this before. It was like, no, wait a minute, this is a real thing, So, that's the part that it's really wonderful to get people like yourself to come out and tell people these things, so they can have these conversations and be advocates in these situations.
Well, again, I think that it's important just to continue educating, because the more times people hear something and the more often we can convey to people, then hopefully that message spreads and it grows and becomes more prevalent within a community.
Brandon just told us here the Parkinson's Foundation has a great tear-off pad with instructions for nurses and providers in care settings, and it's free. That I have seen that is a really good tool. And while we're here, I don't know if Kim, if you can hear me, if you have any questions that you would like to weigh in, and please let us know. That would be cool too. No, I was going to say this information is just why we do this with Life's Copilot, is to bring these kind of resources to the forefront. This video will be in Life's Copilot. It will be in our it'll be on our website. It'll be on our Facebook page. It will go out through different means to get to people. And what we're trying to do is to give people ammunition so that they can know at least where to go to find out. We're not expecting them to have a PhD by the time this is over, but that they can have an idea of that these things exist, what to ask about, who to ask questions of, and go from there. So I really appreciate your time today, Doctor. It's been phenomenal. I just going to say we don't have a question here, so if we can wrap this up if you're ready to. But I was absolutely thrilled today. Thank you so much for your time.
Oh, my pleasure, and thank you very much for having me. And I just want to end on the note of that there are a lot of local resources. I think the Indiana Parkinson's Foundation is a great one, and then each person's provider as well is a really good resource. And then to learn more about Gocavry, there's a website which is gocavry.com.
Thank you very much. Brandon, do you have anything? I don't know if Kim does. Okay. Well, guys, thank you very much. Have a wonderful day.
Thank you. You too.
And we will see you guys soon.
Thank you, guys.
Bye-bye.
Thank you. Bye-bye.